Hello and welcome to the Physician Assistant Exam Review Podcast. We're going to continue with OB here in Episode 5 with RH Incompatibility, multiple gestations, preeclampsia, and eclampsia. My name is Brian Wallace. I'm the host and creator here at physicianassistantexamreview.com, and I want to take just a minute during this episode, episode 5 of season 2, to talk a little bit about who I am and what I'm doing here for people who are new to the show, who are new to the community, and give them a little bit of background. What I did was, a long time ago, it's like 4 or 5 years ago now, I had to take my exam, my PANRE for the first time, and what I decided to do was start putting my notes together. And I came across some other information, some other notes, and that people had done and been posting online and helping other people. And I had always done this in school. I'd always distributed my notes, distributed my questions, passed stuff around to try to help people, because I always put together lists of questions and ways of studying, and I focused a lot on that when I was in PA school. And again, I passed that around to groups and everybody in my class, and I really enjoyed it. I got a kick out of it. I think it really helped people. So I decided when I started to prepare for my PANRE, I would do the same thing. I would start to put material out there online, and it started out as a terrible blog where I would just post some information on each topic and sort of be going through the NCCPA blueprint. But I always wanted to do a podcast, so I decided, you know what, there was nothing at that point in iTunes. Now there's a couple of us who are putting information out there for PAs, and even more who are putting out general medicine. But at that point, there was no PAs and very little general medicine stuff. So I started the very first PA podcast, and that was, my son is going to turn 5 July 1st, so it was right before he was born that I launched the website. So it's 5 years ago, and I started putting together all that material, and I started the podcast, and it was absolutely terrible. You can just start to find the first couple of episodes online now. I think if you dig, you might be able to find them, maybe not. Episodes 1, 2, 3, 4, and 5, I think I may have pulled down at this point, because they're just, like I said, atrocious. And they covered OB, so that's one of the reasons I wanted to do part 2 here. Our season 2 was to start covering OB again and do a cleaner, nicer job, especially those shows I had in the very beginning. So I started putting the material online. I started going through creating these podcasts for audio listeners, and I was shocked at how many people were using the material, how many people were using the show, and really appreciated it and could use it on their trips, use it in the car, use it when they're doing laundry, use it when they're doing the dishes. I get emails from people all the time talking about the different ways it's helpful, talking about listening to it in the car with their kids or their husbands or their wives who they are driving them crazy because they're getting ready for their exams. So so the people in the house are as good at the material as they are because they're constantly quizzing themselves, constantly listening to the show. So I got a real kick out of how much the show took off and how the feedback I was getting about how useful it was. So I decided to keep going. I finished my PANRE. I ended up doing really well, which was nerve-wracking because I now had a bunch of people following along with me as I was taking it, so it increased the level of nervousness if I were to fail the thing. But I ended up doing just fine. And then I kept at this and finished the NCCPA blueprint. It took me a while, but like I said, I was having so much fun, I enjoyed interacting with everybody so much, and the feedback has been phenomenal, so I decided to keep doing it. And as the years went on, I just sort of decided to finish the NCCA blueprint. I did, and then I took a big break because I wasn't sure what to do next. And then just recently, this is episode 5 of season 2, relaunched. For those of you who don't know anything about me, my name is Brian Wallace. What I do in my regular day job, I work strictly in the operating room. I'm a first assistant in the OR at a small community hospital. I absolutely love what I do. I couldn't imagine doing anything other than surgery. I do it all day, every day. Really, really enjoy it. And that's my absolute love is working with my hands, seeing the results right away. So for those of you who are nervous about taking your exam, especially those of you taking your PANRE who are in specialties that you don't think you've been practicing medicine much, I do very little medicine. In fact, I do some medicine in the hospital, but I'm not diagnosing people. I'm not in the ER. I'm not in family medicine. So I get emails from people all the time who say, I'm in dermatology. What am I supposed to do? How am I going to pass this thing? I've been in only orthopedics. Well, I'm in the same boat as all of you in that camp. I have not been practicing medicine. I sort of stopped practicing medicine when I graduated from PA school. I went into orthopedics, and then now I'm in, I do multi-specialty. So I help in OBGYN, I help in plastics, I help in orthopedics. I help in ENT. I do lots of different things. But like I said, I don't diagnose. I don't write a lot of medications, especially for people leaving the hospital. It turns out that this exam, and for those of you taking your PANCE, it's the same thing. This exam is about passing the exam. It's not about clinical medicine necessarily. It's not about what people are using out in the field right now. It is a little bit, but it's really about standards of care, and you can learn that stuff. It's not hard. It's about knowing your key terms, knowing how the questions are phrased, knowing about how they would be described, how certain questions and terms would be described to you, and regurgitating that stuff and being able to sort through it in your brain and pull up that material. It's not about practicing. You learn in school how to practice medicine. Absolutely. You learn a ton of great information. You work on your physical exam findings. You do all of those things. And they try to incorporate that into an exam, but there's just no good way to do it without having a live oral exam. And to do it on written paper in a multiple choice fashion, I just don't think that those of you worried about things like having been practicing dermatology for years, it makes a big difference. I don't think it matters, because what you're doing is you're passing a test, which is all the information is available. It's all in the NCCA blueprint. We cover it all here. It's just remembering all of this stuff that you need to know. And from that standpoint, that's something I've always loved doing. I've always really enjoyed dealing with study habits, dealing with test-taking skills, dealing with how to answer questions, how to dissect questions. And that's been a big focus of where I've been shifting the show in season 2 here, because it's something because it's something I've always enjoyed and something I get a kick out of. And now that we finished the blueprint, medicine once, I want to move more into this studying, test taking, and the way that you can remember more and retain more information. Because I like it, but 2, because I think it's so important for you. And I think as far as passing these exams go, all throughout PA school, and then especially on your PANCE and your PAN-RE, if you know how to take tests and you know how to study, the medicine part is not that complicated. When you get into practice, it absolutely is. I don't mean to undermine that or to say that there isn't a lot to know there. There's just tons to know. But as far as passing the test, it's just about passing a test. So the anxiety and everything that comes with it, I get emails from people who have failed and say, I'm a really good PA. I don't know why I would have failed. Well, you may be a great PA, but you may not be a good test taker. Those are not the same thing. This is about passing a test. It's not about being a good PA. They're totally separate things. And we need to separate them a little bit in our heads and not attach so much of our ego to these exams, and understand that what this is about. It's not a referendum on you personally or on your skills, other than your ability to study and take a test. So that's where I've been pushing the show in season 2 here, is much more toward study skills, study habits. We're covering all the NCCA blueprint material because I know that that's stuff you need to know. I know that's stuff that you want from me, but I also think it's really important to start covering more of the stuff about study skills, study habits, making the most of your time and time management stuff, and also question dissection and working out questions and being good at test-taking skills, I guess is what I'm trying to say. So anyhow, that's my background for those of you who are new to the show and where I'm heading with season 2 here and what we're working on. So right now, currently, we're working on OB. So I'm going to stop rambling on here at the beginning of the show and jump into our review questions on things to get your brain working a little bit before I get into the actual details of this section. So I'm going to ask some questions up front. I want you to take some time and think about them. Go through them in your mind. Try to dredge up answers, even if you don't know them. I'm going to give you the answers, so you're going to correct yourself right away, but doing the physical act of thinking through them, trying to come up with an answer, will help you retain the information as I move forward. So give yourself a shot here. Take a second. Answer them. All right. Question number 1. A pregnant woman comes into your office for her routine 8-week visit. She tells you that over the past week, she's had brown, grape-like vaginal discharge. What's the study or lab you would order? Pregnant woman comes in at her 8-week routine visit. For the past week, she's had brown, grape-like vaginal discharge. What are you going to do? Answer here is we're going to begin with an ultrasound. If a quad screen was abnormal, what test would you offer next? What comes after a quad screen? If the quad screen comes back abnormal, what test comes next? Amniocentesis. What Rh combination in the parents may lead to an Rh incompatibility between the mother and the fetus? What Rh combination in the parents may lead to an Rh incompatibility between the mother and the fetus? Mom's Rh negative and dad is Rh positive. We'll get into that in a couple minutes. At what gestational age is RhoGAM recommended? At what gestational age is RhoGAM recommended? It's at 28 weeks. And again, I'll go through all that in just a little bit, but I want you to think these through and try to make some good solid guesses at this. Give one risk factor for eclampsia. Give one risk factor for eclampsia. There's a whole slew of them. First pregnancy, multiple gestations, obesity, advanced maternal age, diabetes, hypertension, kidney disease, teenage pregnancy, African American heritage. Again, we'll hit that in a little bit. And is urine output elevated or decreased in preeclampsia? Elevated or decreased urine output in preeclampsia? And the answer here is decreased. All right, Rh incompatibility. Let's talk a little bit about it. So in this case, if the mother is Rh negative, okay, and the baby is Rh positive, the mother has the potential to create anti-Rh positive antibodies, right? So if mom has never seen them, if her red blood cells do not contain an Rh positive on them, so her body's never seen that Rh positive factor, her body has the potential to create Rh positive antibodies. Make sense so far? Now, so when the mother's pregnant, the red blood cells don't cross the placenta, but IgG antibodies can cross the placenta. And so why is that information important? So let's just pretend that mom's Rh negative, baby's Rh positive. Well, as long as the Rh positive blood from the baby does not get in and mix with the Rh negative blood from mom, there's no problem. Nothing happens. Everything's fine. Baby gets delivered. No issues. The problem arises when the blood mixes. So if baby's blood, if the fetus blood gets into the mother's blood, she may start producing anti-Rh positive antibodies. So once she creates those antibodies, they can now start attacking the fetus's red blood cells because the antibodies can get through the placenta. The baby's red blood cells don't get out into the mother's blood through the placenta. There's got to be some kind of a traumatic event for that to occur. But once she's made the antibodies, those antibodies can begin to attack the baby's Rh positive blood cells, red blood cells. So the traumatic events that can happen, any uterine trauma. So let's just pretend that there's a car accident and the uterus and the baby have some sort of trauma and the blood mixes there. Or let's say you do an amniocentesis and it can mix there. Again, pretty low likelihoods, but possible. The most common one would be for delivery. At the time of delivery, you can get some bleeding from both the fetus and the mom and get those to mix. And that can cause a problem, not for that child, but for the next child, because mom will have the ability to have made those Rh positive antibodies and they may be floating around. So that's where it comes into play more. So usually the first child is going to be okay. It's the second one where the problem comes in because it's that delivery that causes the trauma that mixes the blood and has mom start creating Rh positive antibodies. Now again, this is only if mom is Rh negative. That's where this comes into play. Otherwise, as long as mom is Rh positive, not a big deal because she's already seen those antigens and it's just not going to be a problem. She won't create antibodies. But if mom is Rh negative, she has the ability to create those antibodies and that can be a problem. If this goes along and mom creates Rh positive antibodies, it can actually be the fetus can have anything from mild anemia because some of the blood cells are being destroyed to actually the fetal demise and stillbirth because the too many of those blood cells are being destroyed. And again, because those IgG antibodies can cross the placenta. So as far as in labs and studies, you do an indirect Coombs test to test mom's antibody production if she's Rh negative. So if she's Rh negative, you do an indirect Coombs test, and that'll give you if mom's producing those anti-Rh positive antibodies. A direct Coombs test can be used to test if the fetal RBCs have antibodies attached to them. So a direct Coombs test will test to see if mom is actually, if mom's antibodies are attacking the baby. You can do antibody titers in mom. You do a fetal CBC and hemoglobin, fetal ultrasounds to be monitored throughout if you have an Rh incompatibility, and fetal bilirubin can be tested. Because if we're breaking down those red blood cells, there should be an increase in bilirubin. Treatment for this is going to be RhoGAM, which is RhIgG. It's administered IM, so intramuscular, at 28 weeks gestation. Remember we said that earlier, 28 weeks gestation. It's just an easy thing to remember. I doubt you'll see that on a test, but it's so simple. It's a little past halfway. 28 weeks gestation, mom gets it. RhoGAM is also recommended within 72 hours of a traumatic event. So if there is some kind of an issue, they do ROGAM again. So at delivery, mom gets it 72 hours after a traumatic event. Another form of treatment would be an intrauterine blood transfusion. If this was something that was already a problem and the baby was anemic and having trouble, you could do an intrauterine blood transfusion, I guess. And then early delivery of the fetus as soon as possible. Next on our list is multiple gestation, so an increasing factor with current infertility methods. Because the IVF is going, the numbers are going up, our multiple gestations are going up. Complications with multiple gestations, complications of multiple gestations, just rolled off the tongue a little funny, sorry, is preterm birth, high blood pressure, fetal growth restrictions, cord problems, so just getting tangled in the cord, nuchal cords, that sort of things. Placenta abruption, placenta previa, we'll get to those later, not today. In the next couple of shows, we'll cover placenta abruption and placenta previa. Just understand that those risks go up. Labs and studies, you're going to follow this with ultrasound. This is how you diagnose it, and then you're going to monitor it throughout pregnancy by using ultrasound to watch both kids. Pretty straightforward. There's really not a lot to know there. I'm not sure what they could possibly ask questions on from multiple gestations. Basically, you're just at increased risk. Throughout, from delivery all the way through, there's just an increased risk for a lot of issues. But the reality is, I'm not sure. I can't come up with a way to really ask questions. You can see that by my review questions and the questions at the end. I tried to take the low-hanging fruit and pick out things that seem pretty obvious to ask questions if I were writing them for a test. And once in a while, topics just don't really seem to lend themselves to that, and this is one of them. Preeclampsia and eclampsia. Preeclampsia is a combination of proteinuria and elevated blood pressure in the late second or third trimester, and it's a precursor for eclampsia. All right, so let me make that a little bit more clear because that's just sort of reading the definition. Preeclampsia is proteinuria, so you have got protein in the urine and elevated blood pressure, and significantly elevated blood pressure. And this usually happens in the late second or third trimester. And this is a tip-off that the patient may have eclampsia coming down the road. And the problem with eclampsia is it's characterized by seizures in a pregnant woman with no pre-existing disorder. So the patient goes into seizures. This can be extremely dangerous for the baby, extremely dangerous for mom. This is a very serious condition. Risk factors for preeclampsia. Do you remember I asked that at the beginning of the show? Risk factors for preeclampsia, and I went through a list of them very, very quickly. See if you can remember one or two. First pregnancy was one. Multiple gestations, so there you go. We have an increased risk with multiple gestations, which we just talked about. Increased risk for pretty much everything. Obesity is a risk factor. Advanced maternal age, especially after 40. History of diabetes, hypertension, or kidney disease. Teenage pregnancy, or African American heritage. So our risk factors are first pregnancy, multiple gestations, obesity, advanced maternal age, worse after 40. Advanced maternal age, which is an increasingly worse after 40 years old. History of diabetes, hypertension, or kidney disease in mom, teenage pregnancy, African American heritage. Clinical characteristics. So here we get a decreased urine output, which is again one of our questions from the beginning, usually less than 500 milliliters in 24 hours. Less than 500 milliliters in 24 hours, decreased urine output. Severe headaches. That's a good one to sort of check off on your box of key terms. Severe headaches. Nausea and vomiting. Again, nausea and vomiting are tough ones with pregnant women, but maybe a change in nausea and vomiting. Right-sided abdominal pain. Changes in vision. That can be, it's a really bad sign, changes in vision. Significant swelling of the hands, feet, and face. And again, a little tough in pregnancy to pick these out, but there should be some kind of change, some kind of increase. Pulmonary edema, and then hyperactive reflexes. Tests and labs. So obviously we're going to get a urinalysis. This is something they do routinely at office visits, during regular pregnancy visits. Proteinuria, greater than 5 grams in 24 hours, greater than 5 grams in 24 hours. Blood pressure greater than 140/90. You can have elevated liver enzymes. We're going to be checking for those. Here's a big one, platelet count less than 100,000. Platelet count less than 100,000. Ultrasound for fetal distress and growth retardation, because you're watching for fetal distress all the time, but especially in these patients who you believe may have preeclampsia, you're going to do ultrasounds to monitor the baby. Complications. We're going to do, first we'll do maternal complications, then we'll do fetal complications. For mom, something called HELP syndrome, which is kind of like just a variant of eclampsia. It's hemolysis, elevated liver enzymes, and low platelet count. So red blood cells start to break down, liver enzymes go up, platelet count goes down. This is bad for obvious reasons. You can get disseminated intravascular coagulation, so DIC, which is super scary, especially in a pregnant woman. I can't imagine. This means that your clotting cascade goes haywire and you start creating clots all over the body. We'll get into DIC a ways down the road. I'm not going to get into a lot of detail here, but absolutely terrifying. And it just has to do with your clotting factors going completely haywire. Disseminated intravascular coagulation, which makes sense based on the name. Cerebral hemorrhage, renal failure, pulmonary edema, and hemolysis. So some very serious complications here for mom. Fetal complications include preterm delivery, low birth weight, and then fetal demise. So treatment. This is one of my something I'd like to pay attention to. As I was saying earlier, things that are easy to write test questions on, I think you should pay attention to. I also think you should pay attention to things that are easy to answer. So in this case, the treatment for preeclampsia is deliver the baby. You don't have to remember any medications. You don't have to remember lots of algorithms and things. It's deliver the baby. Now, do I think every one of you are going to get a test question based on that on your test? Absolutely not. Do I think it's super easy? And if you do get a question, you absolutely have to get it right? Yes. A patient comes in and they describe to you something like preeclampsia. A patient comes in with proteinuria, decreased urine output, elevated blood pressure, and severe headaches. What's our treatment? Our treatment is deliver the baby. So it's super, super simple. If it's before 32 weeks gestation, we're going to try and hold out as long as we can. But things like bed rest may help. Magnesium sulfate for seizure control. Antihypertensives, and this is where it might get tricky. This is more likely where you get a test question on this. Antihypertensives, because we have a pregnant woman, right? So when we talk about antihypertensives, we have to consider the downsides or the risks to the fetus and to mom with some antihypertensives. So beta blockers are really good. Labetalol is one in particular, but beta blockers in general are pretty safe in pregnancy. We can't give diuretics because it's a preeclamptic patient. So they already have issues with their kidneys. They're already having problems. So we don't want to give diuretics. And you don't want to give an ACE inhibitor to a pregnant woman because it can cause renal issues for the baby. From what I found, it's okay in the first trimester, but in the second, third trimester, you don't want to give an ACE. So I think it's just easiest for us to remember, don't give ACE inhibitors to pregnant women because it can cause renal issues in the baby. So eclampsia and preeclampsia are second and third trimester issues, so we're just going to stay away from it. I think in general, it's easiest to remember for you just to say no ACE inhibitors in pregnant women. And so this is pretty easy. This is, to me, where you'd get tripped up on a test question is they might ask you something like, they give you the presentation of, like I said before, a pregnant woman comes into your office for a routine visit. Her blood pressure is elevated, 150 over 90. She's complaining of headaches, and you do a urinalysis and it shows proteinuria. What medications might you want to start right away? And they may have you have to choose between an ACE inhibitor, a beta blocker, and a diuretic. And you're going to have to know that your beta blocker is going to be your safest choice in a pregnant woman in this instance. Okay, so let's talk a little bit about our tip for the day. So our tip for today, and as I said, I've been pushing more and more of this stuff on study, how to improve your brain, how to get better at this stuff so that you can pass this test, so that you can pass school. Tip number one is something people fight me on all the time, and I have so much trouble convincing people of its importance. But it's get 7 to 8 hours of sleep. Study after study that I've been reading shows that memories consolidate and solidify while you're sleeping. So the more sleep you get, the more you retain what you've studied. So if you're not getting 7 to 8 hours of sleep, you aren't remembering as much of what you studied as you should. What I mean by that is if you spend an extra hour studying, let's say, and you give up on some sleep, well, you might only retain 60 or 40% of that hour that you're missing, where you would have retained 80% had you gotten your hours of sleep of the stuff throughout the day. Sleep is when we form our memories, when we create all the important pathways, when we reinforce those pathways. Like I said, I've been reading a ton of studies. All of them point to sleep deprivation wreaking havoc on memory. And I know especially for those of you in school, those of you young children, sleep deprivation is a major part of your life. You need to start doing everything you can to try to get 7 to 8 hours of sleep. Not just getting by on 4, 5, 6 hours and then drinking coffee all day. This is not what's going to be best for your brain, not what's going to be best for you to remember your information, not what's going to be best for you to think and make connections. On your tests, the information is not going to be presented to you in a straightforward manner. You're going to have to think and get things sorted out in your brain. The best way for your brain to function at peak performance is to get 7 to 8 hours of sleep a night at least. Some of you very, very few of you need a little bit less than that. Very, very few of you need a little bit more. I think the percentages are like 5% of the population needs less than that, and maybe 5% needs more than that. There's a bell curve with that. But so that means 90% of us need 7 to 8 hours of sleep. And that will help with your thought processing. That will help with your memories. I can't stress enough how important this can be, especially while you're in school or while you're preparing for your exams. Anyway, let me stop harping on that, and we'll move on to our review questions for today. What amount of protein in the urine of a pregnant woman is concerning? So I've mentioned this several times, describing how a patient might present and how they might write this test question as a STEM on your exam. What amount of protein in the urine of a pregnant woman is concerning? 5 grams over a 24-hour period. Name 2 classes of antihypertension medications you would not give in a preeclamptic patient. What are 2 classes of antihypertension medications not to give in a pregnant patient? Preeclamptic pregnant patient. That sort of says that's sort of redundant. In a preeclamptic patient. ACE inhibitor and diuretics. Here's an easy one. What is the definitive treatment for preeclampsia? Definitive treatment for preeclampsia. Deliver the baby. Delivery solves the problem. Yes, mom's still going to have some issues. Baby may still have some issues. This isn't going to clear it out immediately, but this is how we treat it. You deliver the baby, things improve pretty dramatically right away. Is urine output elevated or decreased in preeclampsia? This is a question from the beginning. Increased or decreased in preeclampsia? The answer is decreased. It's going to go down. You're going to have less urine output if a patient is in preeclampsia. Well, thanks a lot again today. Really appreciate you guys tuning in. I really appreciate the emails, the 5-star reviews on iTunes, all of that. Really, really appreciate it. It goes a long way to keep me doing what I'm doing. I have been hearing from some of you who have been passing your exams, so congratulations on that. Those of you taking your exams within the next week or 2 weeks before the show comes out again, good luck to you. Please let me know how you're doing. Always love to hear results, positive or negative, on your exams. But just to hear from you guys and let me know how you're making out. Love to hear it all the time. So, and like I said, work hard. I'm trying to make an extra effort this week in particular. See if you can get 7 or 8 hours of sleep at night. See if you can maintain that for 1 week, maybe 2 weeks, maybe 20 or 30 days. And at that point, things tend to become a habit. So try to work on 7 to 8 hours of sleep, working back from what time you need to get up, count back 7 hours, get to bed, get to sleep. Thank you, and take care. I'll see you in 2 weeks.